Chronic ankle instability or recurrent ankle sprains tend to be an injury that I'm seeing more and more frequently, especially in the youth and adolescent population. And I don't know if just the prevalence of the injury is increasing or individuals are more commonly seeking out care for it, but regardless, it's something that appears to be popping on my schedule with a little bit more regularity. And I'm actually happy about that because it means that we're no longer just dismissing an ankle sprain as something that's going to take care of itself. And I think oftentimes, and if you spend any time being active in your lifestyle or playing an athletic activity, you've probably had an ankle sprain at some point in your career or your lifespan. And if you're anything like me, you just kind of walked it off, hoped it got better in a couple days, and probably went back out on the field or the court either within the same game or within a few days. And I think what we're starting to realize now is that the effects are not only acute, but they can linger on. And some of the effects that do linger on aren't as noticeable to the naked eye as just bruising and swelling and some of the bigger picture things that happen immediately when you have that acute ankle sprain. So things that we're starting to see with chronic ankle instability and things that we really just need to be mindful of. And I would say we've always kind of understood that it happened, but we're just getting more definitive information with the research, is in regards to muscle activation, muscle firing patterns, and really just movement strategy and how we find athletes moving and performing given activities after they have an ankle sprain occur, meaning they have deficits in proprioception, they have deficits in strength, potentially deficits in mobility, and they're exhibiting these deficits with how they organize and strategize their movement and carry out tasks, either in the clinic or back out on the field of play, to avoid utilizing that ankle and the injured spot. So we often find individuals relying more on knee strategies or hip strategies, or even orienting their trunk and their upper body in ways to offload or avoid loading that ankle in the manner that they would have done prior to the injury. So something that I think we can really stress to our patients is after these ankle injuries, when we've addressed swelling, we've addressed pain, just the aesthetics of the injury have gone down. It's no longer bruised, it's not as nasty looking as it was in those first 24 to 72 hours. That's a great thing, and it means that we are moving in the right direction, but it doesn't mean that we are completely out of the woods yet. And these are individuals that even as they're beginning to get reacclimated into practice participation and eventually game participation, we need to be diligent with what we are screening and what we are testing, not only at the foot and ankle joint, but also higher up on the kinetic chain and really just their overall conditioning profile as well. And depending on how severe the ankle sprain was and what all was involved with it, was there any bony involvement, was it a multi-ligament injury, or was it just a really significant grade 2 or grade 3 sprain where there may be some significant time loss, we do need to make sure that we're doing some sort of aerobic and anaerobic testing with these individuals to make sure that they're matching up with their peers and just the expectation, whatever their sport and position entails for their age and their gender. With ankle sprains, ideally in the beginning, we are clearing up some sort of circumferential measurements. Largely a figure 8 measurement is usually a very easy one to take. You can also just take a circumference around the malleoli as well. That can give you a good indication as to whether swelling is remaining stagnant or moving in a better direction, or potentially a worse direction, and maybe they're getting re-aggravations with introduction of new activities following the injury. Range of motion, we can do your standard 4-way ankle goniometric measurements. You can also do other functional range of motion measurements by looking at closed chain dorsiflexion in a variety of ways in the clinic as well, or just through observations with exercise and making sure that it looks similar between the involved and the uninvolved side. From a strength testing standpoint, easy things early on to do, just manual muscle testing. Isolate inversion, eversion, dorsiflexion, plantar flexion. Make sure that they're able to generate force, make sure that they're able to tolerate force just in a submaximal effort, isolated, very simple environment. And if they can do that, great, let's get them up onto their feet. Let's see what they can do with a little bit more resistance in both closed chain and open chain from there, whether we're going through Y balance testing, single heel raise testing, single leg heel raise testing, anterior step downs, or any of our other just traditional strength training activities that bias one foot versus the other, either through asymmetrical loading patterns or with our unilateral lunging and squatting profiles. With regards to impact testing, you have pogos, which tend to be a very ankle dominant activity, but they don't have a whole lot of excursion with them. It's just vertical displacement. We don't have a whole lot of lateral displacement or horizontal displacement. So it tends to be a good entry point. And don't be afraid to introduce that with upper extremity supported or some sort of fingertip support as well. If that goes well, we can then look into our lateral hopping profile with a lateral line hop test. Remember, the standardized way to do that is with 40 centimeters of distance laterally. You do not need to start there. You can simply have them go over a line and then progressively widen that out to the standardized test over the course of several sessions or several weeks if needed. We have our traditional hop testing battery that you often associate with knee injuries, but it's also appropriate for ankle injuries. And then we also have vertical hopping that we can do as well. If you have force plates available, there's a variety of things that you can do with them in the clinic to isolate either normative data or limb symmetry data. You can also just look at various vertical hopping tasks and see what does their performance and what does their movement strategy look like with that. But I think big picture, what we really need to appreciate with chronic ankle instability is that it's just not the foot and ankle complex that's being involved. You're also going to see changes with movement strategy that involve the knee, the hips, the trunk, and the core. And our training and our testing needs to be reflective of that. And it is not uncommon to maintain a PT plan of care even as this individual is returning to the practice field and returning to the playing field, just to tie up some of these loose ends, making sure that we're having a very holistic approach to their injury, and ultimately putting them in a situation where they are less likely to go back out onto the field in a vulnerable state and less likely to have a re-injury or re-aggravation occur.